everyone. Welcome to the second last session of the program. And in this session, we are going to discuss breaking bad news. I think these are a couple of topics that are very sensitive, very important, challenging. And therefore, I thought that let's cover these topics toward the end when we have at least the basic understanding of what our day-to-day communication should be with the patient and their family members. So if I may ask you, what is your understanding of breaking bad news? What exactly we mean by bad news? Maybe you can mute and briefly explain what exactly we mean by bad news. You can give the name also.
Ma'am, it can range from incurable, very serious diseases to death.
Death, okay. Thank you. Thank you for being to the
And
point.
incurability of a disease also again.
Absolutely. So Dr. Kundan has written in the chat box, news of a patient's death. Yes, I think that's very common bad news that we have to deliver to the family. Something that patient does not feel good to hear. Yes, I think that's very right, Deepika. Anything, and you know what you have said, actually it's a very big spectrum that we have talked about. So I'll come back to that. Dr. Neha has a point to say. Dr. Neha, please unmute and speak. Yeah,
madam.
Yeah.
This is about any outcome which is not as per expectation and which is not good.
Yeah.
Even from the patient perspective, anything that is not a better outcome,
Yeah.
it can be taken as a bad news, that nothing much can be done for the patient. And
Absolutely.
definitely, as Dr. Amrit has said, that
Yeah.
about incurable or any
Dr. Manisha has also written in the chat box, poor prognosis, that yes, they are. Dr. Kundan has written further adverse prognosis like progressive neurological disease, diagnosis of little life-threatening disease like cancer. Absolutely. So if I say you have diabetes, is it a bad news?
Yes, many patients feel diabetes also is bad news,
Yes,
especially
madam.
young diabetes patients, especially.
See, we are so much in habit of distributing diagnosis that sometimes hypertension and diabetes and rheumatoid arthritis, migraine, hearing deficit, visual deficit, these all do not look like bad news. But very honestly, if you look at it from the patient's perspective, they are bad news. I've seen mothers literally fainting in my husband's clinic when he tells that, okay, your child is myopic or he is high myopic. And parents are just not able to believe that how can it be? I don't wear specs. My husband does not wear specs. How can my child have, and especially when they see the thickness of glass, I mean, they are not able to, the immediate reaction is, no, we want to get rechecked. We want to go, we want to seek second opinion. So you can well imagine that idea that I'm trying to, bring home is bad news is not about just very serious illness or about death or some neurological, major deficit. But it could be, as simple as diabetes and hypertension. And if I share my experience with you very briefly, it was almost like maybe I'm talking about 20, 25 years ago when my kids were very, very young. So I had cough and, fever and difficulty breathing. So my husband took me to one of his friends who is a physician. So he examined me and he asked me to get the chest X-ray done. He said, I think we need to get an X-ray done. And meanwhile, I'm starting the, medicine. I'm starting the antibiotics. Let's see what happens. So when we got the X-ray done, there was a kind of a shadow, lower lobe. I don't know left or right, but there was a shadow. So he said it looks like tuberculosis. And let's start with the medicine. And in case if it subsides with medicine and if things are okay, then we are good to go. Otherwise, we'll have to investigate for tuberculosis. And he sent me home. Trust me, those 2-3 days when I was asked to take medicine and wait for things to settle and then get the X-ray done, for me, the whole world changed, upside down. My kids were very, very young, and I had hundreds of questions in my mind. Who will look after my children? Although we all know tuberculosis is curable and there's nothing, very, it's not like cancer that you're going to die or something. But I had so many questions in my mind. Can I hug my kids? Can I sleep with them? Can they sleep with me? Can they eat with me? Can we share our food? Who will teach them? Who will make them, get them ready? Because they were very young. They were going school going kids. I mean, unfortunately, after 3 days, when I got my X-rays done, everything was clear. He said it was just a simple, pneumonitis kind of a thing. But imagine a simple diagnosis like this can completely, disturb you and upset you so much. Imagine the kind of news that we share to the patient and their family. And usually, when you share that information, it comes as a cognitive deficit. The person is not able to register anything because it comes as a shock. So we'll do a small role play before we go further. So in that role play, I'm going to send you all in the breakout room in partnership. So two of you will be in one room. One of you will have to play the role of the patient, and the other one can be the clinician. And I would prefer clinicians who are already doing it, let them be, uh, you know, um, 1 second. Snehal has a message. 1 second. So Snehal, you think you will not be able to participate, or if you may just unmute and say.
Yes, ma'am. I'm trying to listen, but there's a young child, and
It's okay.
I'll be in and out.
It's okay. So do you want me to put you in the breakout room, or you just want to be an observer?
I'll be an observer, ma'am.
Okay, no problem. So I think I'll put everybody else. And even if I put you in the room, you can just be quietly observing. You need not take any. That's okay. Yeah. So what I'm trying to say that in that situation, I'm giving you a very simple situation. Your patient is a young adult and diagnosed with CA pancreas. It's all established already. All investigations are done, and now it's time to just kind of communicate to them that yes, it is CA pancreas, and then take it further. So what I want you to basically get into the role. So one of you play the role of the doctor who is breaking the news. Those who have been into that place, like you are already doing it, so I want you to play the role of patient rather than, because if you're already doing it, I'm sure you will be able to do it more or less in a effective manner. So first do that breakout room activity, and then we take it further. So the activity is clear to everyone. Any questions? Dr. Kundar, you want to ask
Is
something?
the patient who has the cancer or the attendant?
It is the patient. It is, or maybe what? Yeah, I thought that I'll have one patient and doctor, so that we actually intensely get into the role. So therefore, I did not have the role of attendant here. I decided that we will be just the patient and the doctor. So let me put you in the breakout room, but why can't I see the breakout room? Yeah, there are. So I'm sending you to the breakout room, and it's just 2 minutes activity, not very long, 2 to 3 minutes. That's all. So I'm creating just 4 breakout room, uh, and Sneha, you can be in one of the. Yeah, Sneha will be. Give me 1 second to. Okay, so I'm opening the room. Please join the room. So Priya, please join the room that you have to join. So who is not there? Somebody has dropped. Okay. So how was it to be there? I think I'll ask the patients first.
Ma'am, actually, to be very honest, you can only relate to this kind of a thing if you have gone through something like that. And even your reaction, your acting or whatever it is, even the role play will be genuinely affected by your experience of it or not experiencing it.
I agree, but
This
then
is how
I
I feel.
think just playing that role, I heard you saying that you don't want to even imagine something like this.
Yes, because I was relating it to something that similar space I have been in, and I was also relating it to something which happened about 2 years back when my father, who was a hale and hearty man, he was diagnosed with CA brain. So I could actually go through the emotions. And Dr. Deepika has been very convincing and very I'll say her demeanor has been very appropriate.
I understand. And I really feel sorry for what you have shared. But I understand. I think this is one thing we all have seen in our family with somebody or the other. And I think we can relate with it. And being in that space is something that I wanted all of us to experience, that it's not easy. It's not easy. So those who played the role of the patient, if you can one by one briefly tell what did you experience, but briefly. Who all
Yeah.
played the role of a patient? Okay.
Yes, ma'am. Good
Mani-
evening.
Neha, Mamta. Okay, let's ask Mamta first, then I come to you.
Yeah,
Dr.
ma'am.
Yeah.
As a patient, to receive this news is very stressful and panic stage, actually. Dr. Kundan, of course, he is a doctor, so he played very well role in convincing that he's there, some mutual support, psychological support, and asking whether I need my family members to be there or not. If not, why? And kind of that support itself builds the patience that I felt, ma'am, that we are there to help you, no problem, though it's difficult situation, but still it can be treated, like giving some hope. Yeah, ma'am.
Thank you. Thank you, Mamta, for sharing that. So actually, you talked about what Dr. Kundan did. I wanted you to more talk about what did you feel being there. But it's okay. I can let Dr. Neha do her share of talking, and then Dr. Manisha. And then I think, yeah, go ahead, please, Dr. Neha.
Madam, I could also to some extent relate because in my family, my real Mosa had the cancer and treatment was going here only. I mean, when they were here and finally he's no more. So, I mean, it was a really, I mean, very intense situation knowing that cancer is diagnosed. I mean, something, I mean, cancers, although Dr. Priya said whatever convincing word, but I could really feel it is really a tough situation for patients. And definitely when the doctors are saying something, we want to hear more in the terms of common language
Day-to-day language.
and day-to-day language, and mainly उसके क्या effects हो सकते हैं, because that is more required rather than I felt listening ki okay, everything will be fine. So we
So
want.
if I ask you and others also who were playing the role of patients, what were your questions? What were the thoughts on your mind?
So
If you look
like
at it from patient,
first
like
thing,
you said, you want to know
yeah,
more.
first thing was कि मुझे कैंसर हुआ है, तो ये मतलब वरी ना करने की चीज कैसे हो सकती है. Like first word मतलब when I कि do not worry.
So इसका मतलब अगर कोई डॉक्टर ये कह रहे हैं कि चिंता मत करो, this is
so
not going
ये
to help.
because
this is not going to help in any case, and this should never be said.
Because cancer is something which is, I mean, first if doctor says ki there is no need to worry so much, but we have diagnosed this thing, so cancer can never be a thing of not to worry.
Worry free, cannot be worry free. I agree. Okay, let's give somebody else a chance to speak. I think Dr. Amrit has raised her hand. Yes, Dr. Amrit.
Ma'am, actually, if taking it practically, I think the moment the news is broken, you stop listening. There is nothing else that enters your mind.
Yeah, yeah.
It is just you and that big fear that is there. I think nothing can kind of match that.
Well, I will share with you the presentation in which I have talked about the cognitive deficit that happens because of the shock that you experience because of the diagnosis you hear. You will understand why we are not able to register anything, because that word itself is like, it completely dazes you. So you lose touch with reality and you are just so confused and overwhelmed with it that you are not able to logically think or listen to anything. And I completely understand what you are trying to say, Dr. Ambi. Yes, Dr. Manisha, if I may ask you, like, what were your concerns when she was, your therapist was sharing with you the news? What were the immediate thoughts?
Ma'am, first of all, it was non-acceptance that this can happen to me.
Yeah.
So, like I was pursuing her कि टेस्ट वापस करा लेते हैं, वापस से आप देख लीजिए, एंड ये नहीं हो सकता, मेरी लाइफस्टाइल अच्छी है, मैं हेल्दी खाना खाती हूँ, ये नहीं हो सकता, मेरे छोटे बच्चे हैं, कैसे होएगा? So no, you go into a denial.
Denial. I think what you're talking about is denial.
Denial.
Which is
That-
again a psychological process.
Denial that this cannot happen to me because I have been, over a period of time, I have been living a healthy life, according to me, whether it is healthy or say.
Yeah.
So you don't want to listen, and of course, then other processes happen that you are numb at a point.
Yeah, thank you. Thank you for sharing that. And now I want to go to the therapists who were doing the role of, breaking the bad news. So what did it feel to be there? I would ask Payal first to share her experience.
Yeah. So, ma'am, first of all, if we have to tell something, a very big thing like, the cancer to a patient, we really wanted they should be surrounded with the family. Or first, I would like to talk with the close family rather than first treating or further, like first toward the patient only. And want to understand how psychologically they feel that, if it is so much breaking for them, they should be surrounded with some family. And rather than a doctor or family person should also be tell them this is going to happen. And
Payal, imagine if we look at the patient's rights, that says that we have to first talk to the patient, and with the family we have to only reveal if the patient permits. But if we look at the social fabric of our country, it is always the family who would be interacting with the treating doctor, and patient is just a mute spectator. And lot of time, of course, not now, but I'm sure in the time to come, we are going to have lot of legal, cases just for this reason, that how did you share my information with my family without my consent? Right now, we are not taking any written consent. We are not even taking a verbal consent, honestly, but we are going on the assumption if it is the family who is putting in everything, so they are the one who need to know what is the diagnosis and what is the prognosis. But very honestly, I think all young doctors should be ready for something like this that may happen tomorrow, where your patients might say that you can't share my information without my consent. And I never gave you consent. So you have actually broken the, it's a breach of contract. So I just want to bring that also. So emotionally, how did you feel, Payal, when it came to doing that role?
So I also felt, I get connected with my role and with the patient also, that, how they are going to feel. And when they are in the denial, how may I proceed further with the treatment, right? If the patient will not accept only that they have something, then how could we help them to go ahead? They are like, they will not.
Actually, I could overhear when I entered your breakout room. And I heard Dr. Manisha saying that, can we get the test done again? Are you very sure that it is, this is my report? So, I mean, this is very common. This is very common. This is a part of denial. So as a doctor, sometimes we get, not that we get annoyed, but we really don't know how to handle that emotion. How do we respond to that emotion? Because when patient is not ready to accept, they may even say, no, we will go, we'll check with some senior doctor. They will not say second opinion. And the moment they say, नहीं हम किसी बड़े डॉक्टर को दिखाएंगे या हम किसी बड़े हॉस्पिटल जाएंगे, I think that's more than enough to upset any doctor. Am I not a bada doctor? And is my hospital not a big hospital? So because patients don't know what they should be saying and what or how they should be saying whatever they want to say. But the moment they say we want to go for second opinion, it can upset the doctor, and doctor can say, ठीक है आप दिखा लीजिए मैंने आपको report दे दिया, and they will just close the discussion then without actually taking it further and managing it. But I think you are right. That's a very big concern if we don't know how to handle that denial part. And through the presentation, I'm going to talk about all these aspects of therapist concern, how you can empower yourself with the right knowledge and skills to deal with that is something that we are going to listen. So if I may ask Deepika, how did it feel to be there, and what were the questions? What were the thoughts on your mind?
Yeah, ma'am, actually, this is the first time that I had to, play this role, which I've never done in my past, fortunately. So, first of all, I felt very uncomfortable to, initiate the discussion. But with whatever understanding that I had, so I first took a verbal consent from Dr. Amrit to check if she has come along with some family member, and if she wants them to come inside the room so that we can discuss about the results.
Yeah.
And also, as she was also trying to relate, and then she got into the role, I understood that she needed a lot of time. So I didn't want to put a lot of pressure asking her if she understood what I'm trying to tell her, or if she has any questions about it and all that, because I felt I should be respecting that there will be a lot of emotions going on through the family side, and I should value that. And also the third part was I also used a lot of words of reassurance, which I felt that she might require, and look into the future rather than talking more about the diagnosis. So I gave her the options that there are psychological counselors available in the team, and she could be approached by anybody, and she can approach anyone, and we could work together as a team and see what best can be done to solve this thing. So these three aspects is something that I understood from the role play. Did I get stuck?
Ma'am, I have a question.
To soften the blow. Am I audible?
Yeah, but
Yes.
we lost you in between. Yeah.
It's showing my internet connection is unstable. Am I audible now?
Yes.
So a lot of time we reassure the patient, because I heard even Payal doing the same. She was reassuring the patient, don't worry, there's not much to worry. We have a lot of options available. 1 second, doctor. Give me a second. I'll give you a chance to speak. So at times we are giving that reassurance just to soften the blow. But very honestly, this can misfire. This can backfire. Patient might quote you later on saying कि आपने कहा था कि इलाज है और आपने कहा था ठीक हो जाएगा. आपने कहा था कि इतनी घबराने वाली बात नहीं है, और आपने मुझे कहा कि बहुत ट्रीटमेंट्स अवेलेबल हैं, तो मुझे तो यही लगा कि बाकी चीजों की ट्रीटमेंट होती है. I'm sorry, Deepika, I'm speaking in Hindi. I promise that I will not use Hindi because Deepika is little uncomfortable because she's not able to understand Hindi, so I will continue with it. So at times, just to soften the blow, we use such words, not with the intention to mislead the patient or to confuse the patient, but it actually creates confusion. So when I say like this, see, there are a lot of treatment available. Don't worry, there's advancement in technology. A lot of treatment options are available. Don't worry. How do I know which stage of cancer it is? If it is already metastasized, if it is already, stage 4, and then I'm saying there are a lot of treatments available, and then everybody is happy, and then I say, okay, you have just this much of time. I'm creating a lot of confusion. So every word that you say, especially when you're breaking bad news, it has to be weighed very, very carefully. We think by reassuring, we are able to make our patient calm down. I understand the intention, but it is very risky. That's the word of caution I want to give here. So if I may ask, Priya, what was your experience when you were doing the role of a therapist? And then I'll come to Dr. Kundan in the end. Yes, Dr. Priya.
To start with, even the thought of breaking a bad news was kind of a scary situation, to be very frank. And I was already thinking what would be the response, what am I going to say? To be on a safer side, I picked up stage 1.
Yeah, Priya, hold on. So somebody's mic is on. Can you please mute? Can everybody mute their device? Because there's some background talking going on. Yes, Priya, go ahead, please. Yeah. Unmute. Priya, please unmute your device. Yeah.
So I started off staying in it's stage 1. So don't worry, exact word which you mentioned, you should not be using.
Yeah.
So the moment Dr. Neha responded, I was really worried. I was like, what do I do now? What do I do next? There's no attender as well along. So I was, trying to actually convince her or pacify her or, try and make her understand, which actually was in vain. It's a very difficult situation to handle.
So I think one realization all of us must have, that it's a difficult task.
Very.
Even seasoned clinicians, they have that, palpitation before they go to break bad news. Unless they've really done their job very meticulously and they have continuously updated the family, prepared the patient, then probably it becomes easy because somewhere there is already an acceptance. But when it comes as a sudden news, and for the first time when you are breaking this news, it can be actually, there can be any kind of reaction coming from the patient party. And I think your concerns are very, very, understandable, Priya, that, I mean, it is not an easy discussion to be done. But thank you all of you to have done that role. So coming to Dr. Kundan, I'm sure I saw you speaking very confidently with Mamta. I entered your room, I quietly heard you talking to her. I mean, I'm sure you must be already doing this. So it must have been quite comfortable for you. Am I right?
No, actually, yeah, madam. I agree with whatever points have been raised.
Yeah.
It is never, so in spite of so many years of practice, every situation is different. Every situation is new. So I think breaking bad news has been always a difficult area, especially when if you want to break a news of some death of a young patient, especially if some young patient with lot of dependence on that patient, young, and all a pregnant lady that. So all these are very difficult, tough situations, what I feel. So this role play also, I felt that it is, in spite of experience, you feel that sometimes, because you never know what reaction the patient might come. It may be anger, it may be depression, it can be denial, it can be blaming also. Many times it can be blaming. Doctor, you were treating me for so many days. Why did you diagnose the cancer so early? So I think, yeah, in such cases, what I personally feel is that as you have rightly mentioned, that whatever words we choose, or whatever non-verbal communication has to be very meticulous from our side, because patient will keep on observing whether there is any guilt in whatever we are speaking, whether there is any firmness, whether there is any casual attitude, or whether there has been some empathy, or so many things are blaming also. Sometimes, treating doctor also blames some other, why did you come early if the cancer was there? Or why did you go to that doctor, that kind of. So I think whatever that situation, what I feel personally is it can be done in not only one part, except death. Death has to be discussed all. But if there is some chronic disease like a cancer or diabetes, I think it can be done in parts. First part may be disclosing the, like in this case, even like if you want to disclose pancreatic cancer. Cancer has a lot of treatment, has so many aspects, like what is the stage? Like Mamta ma'am was rightly, and I think she played a role very well. She rightly asked, what are my chances of survival? To the point, many patients ask the same thing, doctor. What is the chance of survival? And will I die? What will happen? So I think those answers many times we also don't have. Like unless we have the PET scan, we have the oncologist opinion, we have so many experts coming on, and many times the expert's opinion also changes in cancer, especially. So I think just first interview, disclosing, showing empathy to the point, and asking pertinent questions, answering pertinent questions, and then we can always maybe call back subsequently the patient and complete the remaining part of the discussion, what I feel personally, but maybe every
I
case
think
is
you have
different.
pointed to a very, very pertinent point, Dr. Kundan. Especially when there is a cognitive deficit, patient is not hearing anything. Patient is not able to understand anything because the patient is shocked. But patient is definitely observing your body language. So your non-verbals at that point play a very big role. If you appear casual, if you appear unaffected, or if you appear that it's a routine job that you are doing, or you are in any kind of hurry, or you are not interested to answer their question, that actually aggravates the situation. So most of the aggressive reactions trigger when you break bad news. And one of the major reason is because when we don't do it in a sensitive manner, when we are not able to demonstrate that we are understanding your pain and we are also, feeling bad about it or feeling bad about you, but this is something not in anybody's hand and we are not guilty of anything, so that the patient doesn't blame you for that. I think that is where we need to focus our training. We really need to train our young doctors, and most of the breaking of bad news, especially if you look at the critical care area, it is done by residents a lot of time. Not many consultants even would come in the picture to come and break. If they do, I'm sure they'll do it a much better manner because they have learned the way. But unfortunately, most of it is done by the young doctors, and when they do it, they don't know how to actually, like Dr. Amrit was talking about the demeanor. They are not even aware of their own demeanor. What is their body language? What are their facial expressions? And then they are not able to actually have the right demeanor, which would actually build connection with the patient party and also communicate that, I have done my best. I wish I could save your patient, or I wish I could. That is where, and it's not just non-verbal. I think sometimes even our verbal communication go wrong. And I can give you two incidents that they're real life situation I'm talking about. So in one hospital, a very young boy, maybe 15, 16 years old boy, he was actually running after the kite and unfortunately touched the live, air cooler. And unfortunately, it had a live wire touching it. He got electrocuted. And immediately the family took the child to the hospital. They did CPR and they announced that, sorry, actually it was a case of broad death, but they did their, duty of doing CPR and they announced death. Now, family goes out and somebody outside says to them, go and tell them to do CPR once again, because sometimes patients, patients come back. We have seen some cases where they have disposed the fetus, saying that it is dead fetus, and then they are able to see some movement and some heartbeat. And there have been, those accusations that we have been careless in handling the. So same way, this family is, asked by somebody, go and request them to do the CPR once again. So this family comes in and says the same to the resident. Okay, doctor, please try once again. Maybe. And imagine, anybody losing their young son all of a sudden with no disease, no problem, and suddenly, dying because of the unfortunate incident. Now, what does this doctor say? He said, doctor, मैं हूं या आप हो? आप कर लो. मेरी तरफ से तो बच्चा मर चुका है. आप करके देख लो. So Deepika, I'll explain it for you. He said, I'm the doctor. So if you think you can do it, you do the CPR. I have done my duty. This was the resident who said. Now we may say, okay, residents are young, they are still learning. Now in another case, a young boy, he was on his way to distribute his sister's wedding cards. This is again a real case of Delhi hospital. I did initially, I think 500 training programs, so I got to really know the incidents that are happening in hospitals and how we are managing them. So this young boy, he was on motorbike and he was on his way to distribute his sister's wedding invitation. And unfortunately, on the way, he met with an accident and he died. Now his dead body was brought to the nearby hospital and family was informed, family came in. So since it was a road traffic accident, so they had to do postmortem. And it was evening hours, so, and this hospital did not have the facility for postmortem. They had to call doctors from the other hospital to come and do the postmortem. So they said that, okay, we are, putting the body in the mortuary and tomorrow morning we will be doing the postmortem. But the family, because it was a sudden death and they were already in the mood of celebration because there was a wedding in the family. So they requested the doctors that could you please do it? Either don't do it because it's a road traffic case. But of course, we know legally whatever has to be done has to be done. So they requested that if it has to be done, then please finish it off today so that we can, even do the cremation today. And then think whether we go ahead with the marriage or we call off the marriage or we postpone. I mean, these were the points they were discussing. Now, these doctors, blatantly said that nothing doing, it's not possible today. They go to the medical superintendent of the hospital, requesting him, sir, please get the postmortem done today so that we can take the dead body. And can you believe what was the dialogue that came out of this medical superintendent's mouth? He said, Deepika, I'll say in English first, in Hindi first, and then I'll explain to you. मिट्टी है, देख लो, चाहे आज करवा लो, चाहे कल करवा लो. So the comment this medical superintendent made, Deepika, he said, these are ashes now. It's a dead body now. Whether you get it done today or tomorrow, it doesn't make a difference. And what must have happened after that? You can well imagine.
There might have been they might have be aggressive.
Definitely,
They might
definitely.
become aggressive.
As it is, they were shocked. They were in grief. Over and above that, if this is what we are saying, so no amount of age and experience can actually decide whether you will handle it in a sensible manner or not. I think this should tell us clearly that it is only through learning we get to understand that these situations are very intense. Emotions are very high. Tolerance, patience, understanding, logical thinking, everything is just out. So we have to proactively be mindful of our communication, verbal communication, non-verbal, body language, tone of voice. Everything has to be very carefully, kept in mind that what has to be my demeanor, what has to be my verbal communication. Only then you can handle such intense situations, in another thing. So let me quickly share the presentation with you because that will help us understand what is the right way of doing. And from that, of course, we can all design our own communication depending upon the situation you're handling. But these guidelines can at least tell us what are the do's and don'ts. If we are able to even remember that, I think it will help us in handling difficult situations in a more practical manner. So any questions about the discussion that we have had till now?
Yes, ma'am.
Yeah, Mamta, go ahead.
If not being very sympathetic or not showing empathy to the patient, so how firm should be the communication to the patient in breaking this news, ma'am? Because sometimes the patient may not able to receive it. And
so more than being firm, I think you need to be clear in your communication. Don't beat around the bush. If it is death, we have to tell that we have made all efforts to save the patient, and you saw us working on the patient. We have done, whatever we could do for the patient, but unfortunately the condition deteriorated and his, cardiac activity and his respiratory activity suddenly ceased. But when you're saying this, you have to be, but when we say confusing things, let's see, I think there is a possibility. Let's see, we are trying. That is what confuses. That is what, after everything, they'll say, Doctor Sahab, bach to jayenge na. So that is where we are making this. I think once you will listen to the protocol, you'll get more clarity. It's not about firmness. It is about, because if you think I'm being firm, you could actually be being authoritative, or you could be intimidating. So I would not advise you to be firm, but very clear communication. And your body language, your tone of voice has to express empathy, compassion, understanding. That is what I think is required in such a thing.
Ma'am, I also have a question.
Please.
it is as when we are the doctor who's breaking this news to the person. I think at that time the patient is only, I mean, everything that the doctor is saying positive, like things will get all right, or we may help you and everything. So the patient is supposed to cling to all those words which are showing some hope. So, I mean, I think we should be more very, very careful about giving those clues also कि हम ये कर सकते हैं या ये ठीक हो
That is
जाएगा
what I
या
said right in the beginning, Dr. Amit. That is what I said in
हाँ
the beginning, that please do not give any
or
reassurance that is not
yes,
realistic. You could be
it can
actually,
actually backfire.
yeah. So you should weigh your words. You should be very clear about what you are saying. You are absolutely right. I think you're actually kind of re-emphasizing what we have discussed, and I completely agree with you. Absolutely. So let
I
me.
actually logged out during that time, I think.
Oh,
Sorry.
no problem, no problem. So let me share this screen quickly and go through the presentation. We have done a lot of talking about it. So I think maybe we will not have to do a lot of discussion because we have already covered a lot of points. But whatever we have not covered, we will definitely discuss that. So we discussed that bad news is not only death and serious condition. Anything that has indirect bearing on the family and society can also be a bad news. Now, Parkinsonism, patient would live for 20 years, but imagine the family's condition, or individual's life and future. All that is also a bad news because it has an impact on the individual's life and the not only the patient's life but also the life of the other family members. So we have done this role play, and I'm sure you got an idea how it is difficult either to be in the chair of the patient or even the clinician who is going to break the bad news, because we know that it is not easy. There are a lot of thoughts going on in the mind. So what are the usual concerns that the doctor would have before breaking the bad news? If I may ask you to write in the chat box, what do you think are the usual concerns that the doctor would have? Can you think of some? Absolutely. Very common is what is going to be the response? How is patient going to take it? And especially if the patient disagrees or blames me, I think that's going to be a very big trouble, because then how do I convince the patient that it's none of my fault and I'm not guilty of anything? Or to show empathy at the same time to the professional, showing hope at the same time being practical. Yes, there's a very thin line and it's a very tricky situation. I completely agree. So emotional reaction, which is very unpredictable, yes, and we don't know how the patient might react to it. And there can be a question from the patient that why me? And how do I handle that question? How do I answer that question? Now, for example, that young doctor who passed away, that 41 years old young doctor from Ahmedabad, I mean, in spite of such a healthy lifestyle and himself being cardiologist, if he had a heart attack, I mean, you would say, then what can protect me? What can give me assurance that I won't have it? Now, whether patient will doubt my treatment all along, yes, because the patient might say that you probably did not diagnose timely or your diagnosis was inaccurate. And then how to communicate, what to say, and what will patient say, and how will the patient react? Absolutely, Santoshi, you're right. Reaction and feedback on overall treatment done. How to handle patients' emotional reaction. I think that's also one of the major concerns a doctor would have. And then doctors will doubt and worrisome. Yes. Whether patient would turn up for follow-up treatment or might look for another option. Yeah. That means the patient may lose faith in me and may just disown me and go to another doctor for treatment. And that also happens a lot of time. And then how and how much to say yes, whether the patient may sue me. I think that's another very, very major concern, that if in case the patient thinks that it's my fault, or I haven't done my job well, so patient can even take me to legal side. So absolutely, I think these are very common concerns that the patient would have. The family would have their own questions, their own set of questions. Family would usually be worrying to know what it is, why it is, how much time I have, how serious is the condition. But patients actually value doctors who communicate clearly and empathetically and provide explanation, and they involve the patients in decision making. Lot of studies support this idea. So that means talking to them in an empathetic manner, but communicating in a very, very clear and honest way, where whatever their questions are, if they are answered well, and then while choosing the treatment option, rather than you saying, let's go ahead with surgery or go ahead with chemotherapy, tell them what are the pros and cons of each, and what order actually would be a more useful order, and you involve them. That's what actually patients value. Incidentally, the studies suggest almost 50-60% of the patients wanted to discuss life expectancy. So very often you will get to hear from your patient, how much time do I have? Although it's a very difficult question, but I have seen patients asking this, how much time do I have? But only very few of the doctors are able to give them any, I won't say precise answer, but at least an answer that is satisfactory and that tells them something about it. And almost 60% of them wanted to discuss the effect of cancer on their other aspects of life. But incidentally, since we are more disease and pathology oriented, we talk about only treatment and diagnosis. So how is that going to impact the patient? So for example, if patient says, I have young kids at home, or patient says, I can't afford it, or patient says that I live at a very far off place, I really don't know how will I manage coming here. So these are all very genuine, concerns. But treating doctors would not, venture into it. They would say, that's your outlook. You will have to see how you can manage it. But answering those questions, I mean, unless we really are comfortable taking those questions and answering, that is where the real, rapport building and connection, form. So this one slide I am sharing with you. So they're carrying actually a dead body in that small truck behind it. And they're carrying a banner in front of it saying that this lady died because of the negligence of Dr. So-and-so, and he should be punished severely. Now, I don't know if any negligence actually happened, but I'm sure there was a communication gap. So when we don't inform the family, when we don't prepare them, when we don't clearly spell that out, there's all possibility that patient might think that we have gone somewhere wrong and we have not handled the case properly. So breaking of bad news is one of the trickiest and most difficult communication, because when you have to discuss about things like life, death, poor prognosis, complication, it's not easy. And I think you all have just now done the role play and you realize that, I mean, it's very difficult to even find the right words to say whatever you want to say. And most of the aggressive reactions occur after the breaking of bad news, especially after the death of the patient. Please remember, family has nothing more to lose. So there is all the more possibility that their patients would, break all, what do you call that? Break all? There's a term, no? So
hell breaks loose.
Yeah, hell breaks loose. So they would actually lose their patients and they may behave, the way they want to do it. And as I said earlier, also younger doctors experience more challenge because they have difficulty, first of all, understanding others' emotions, and also they're controlling their own emotion. So I get to hear sometimes from the, wherever I do my program, that sometimes if there's a death in the emergency department and the family members are there and they're crying, sometimes a young resident would say, please go out and cry. Don't cry here. There are other patients. So we are not able to understand the sensitivity of the situation. Or sometimes, I mean, I've heard them saying that they'll be, sitting and giggling with each other. Dead body is still there, right in the same place, families going in and out, and doctors, sometimes they're giggling with each other, or they are, telling, from where should we get our dinner? I think let's get biryani from that hotel. That biryani is very tasty. So we don't know how to behave in such situation. And these things can trigger extreme reaction, because family suddenly, if you remember the last session we discussed, when do they become aggressive? When they feel that they are, victim of unfair behavior or unjust behavior, that is where their patience get lost, and then they can, react extremely. So as young doctors, I think our doctors should know that there is a certain amount of sensitivity that is expected from their behavior. So I remember when we were kids, and if there was a death in neighborhood, our parents never allowed to have the TV or radio on that day. And even if we wanted to watch TV, they'll say lowest volume so that nobody can hear the noise outside. That was the sensitivity we were. So same way, I think, as long as, I'm not saying that we have to sit and cry with the patient's family, but as long as the dead body is there and patients, deceased relatives are around, we can maintain a more calm, composed, and respectful behavior towards patient and the family. But yes, breaking of bad news itself require advanced level of communication skills and great experience in handling emotions. I think deeper understanding of emotional reaction will help us know why things become so intense and how do we handle it. So one really has to learn what words will work in that situation. How do you handle emotions and the questions that will come from the patient party, and then how do you handle your reaction? Because the moment they say that we want to go to another hospital, we are not happy the way you are handling, or we want to show to a senior doctor, anybody can lose control and become aggressive. So a word of advice that I want to give to all of you: please build rapport with every patient, because you never know which case might turn into an emergency. I've seen patients getting test dose and collapsing. I'm sure you also must have seen something like this. So we need to be really, if you have that impression on the patient party that we are all very responsible and professional people and we look after the patient very carefully, in case if something of that sort happen, usually family would not blame. Otherwise, usually the blame is that we have been careless in handling the situation. So creating familiarity actually can reduce the risk of aggressive reaction. Lot of studies support this opinion. So if you are familiar with the patient and the patient party, they are less likely to be aggressive with you. So regularly update them, talk to them, address their concerns. I think this is where you may need to invest some time. They may ask you about the longevity of treatment. They may ask you the outcome or the financial implications or any relapse chances. So those concerns actually should be addressed with patients, which I'm sure requires some time. But I think for such cases, there is no harm, giving enough time to the patient's party so that they feel that they were heard, that they were given a chance to discuss. And then also don't forget to involve them in decision making, because, for example, you put a patient on ventilator and it suddenly doubles their expenditure. And we have informed, but we have informed more like more like an order, or it's just a information that we are saying that please sign, you need to put your patient on ventilator. That's not involving in decision making. That's like you are getting signature because you have to take signatures before you put the patient on ventilator. So that's not involving in decision making. So we need to talk to them and explain them why ventilator is required and how is that going to help the patient, and then put the ball in their court and ask them, are you okay with it? Are you? And in case if they don't agree, we can't be. Otherwise, what we say, please then take the patient from here if you don't want to follow the treatment instruction. So that's not the way how we should be handling this situation. Overall, I think transparency and honesty goes a long, long way in building that trust and confidence in the patient. Because in case if they ask to go for second opinion, if you're okay with the idea, if you provide them with this summary, if you're ready to talk to their doctor, in case if they have a doctor in the family and they say that my doctor, friend or relative wants to talk to you, if you're open to talking to them and explaining to them, they feel that we are ready to, communicate with the family and we are honest in our this thing. Okay. So I think one thing we need to understand, whenever the patient is in critical condition, the family is actually looming under a big fear, a very big fear, because, and what is that big fear? Fear of death, fear of death. So imagine anybody's mind would go, haywire when they get to hear about death of a family member, especially when it is not, anticipated. When you were hoping, we have seen patients who are recuperating, whom we are actually about to move from ICU to ward, or even going to discharge them, but unfortunately, they suddenly have a, cardiopulmonary arrest or some drug reaction. So the family is just not ready for that, something of that sort. So studies have shown that we look after the patient, but we do not, consider the family as the beneficiary of our care. Whereas if we look at our Indian medical system, it is the family who is actually suffering the most. I would say patient is far more comfortable than the family. Patient has a bed, patient is getting medicine, patient is getting medical attention, patient is getting nursing attention, everything on bed. It is the family who is running from pillar to post. They have to arrange for finances, they have to look after the patient, then they have to also, look after other family members who are at home, and who knows what financial, challenges they are facing, and plus the emotional impact of the disease. So I think we need to really involve them in decision making and also address their emotions, so that they feel being heard and being involved. So whenever the patient is in critical condition, if you need to update or break the bad news, I would say it should be done by the senior most person in the system, because they'll be able to handle the situation in a more mature manner. Of course, juniors can be present to observe and learn from that. But, or the person who is actually handling the case. It is usually, there's always a senior consultant. So he's the person who should be breaking the bad news. So I'm going to share a protocol of breaking bad news with you. There are many protocols available right now, on Google and various other platforms. This I find simple and easy to understand, but you can always, check for other protocols which you would like to use. So this says that before you go and break anything, you need to do a part of preparation. So that is preparation of yourself, because you are the one who's going to do it. Then where you are going to do, and about the patient also. We'll talk about it in a while. And then you go and perform. After you have done, you palliate, and then you plan what you're going to do next. So, for example, if you talk about preparation of the physician, I think it's very important to first of all know and confirm all the facts. A lot of time we go to break a news and they say, Doctor, has that report come in, that particular report? And you have no idea about that report. And then you kind of baffle and you are confused. They will have a feeling that you don't even know the complete case and you have come up with such a big news. So read patient's case sheet, be very sure what all has been done, what investigations have been done, what is the finding. And also, a lot of time, I mean, we have seen this, one patient's report gets attached to another patient's case file. And we go and break the news, and then we later on get to know that this was not this patient's case. So we have to be 100% sure that these reports belong to this patient to whom we are going to do. Before you actually start saying, okay, your reports are ready, have come, and this is what we have seen, it's very important to do, kind of a small talk before the big talk, or make connection with the patient and the family. So for example, if you ask a simple question like, how are you feeling? Is your pain any less today? Or could you take something today, because you were saying you were not able to take anything? So when you do a little bit of, this small talk, they kind of, or in case if there's somebody with the patient, so you're asking that who is this with you, and how is he related with you? So again, it's like building connection, with the patient. So there are some answers some are not answers, but some opinion in the chat box. I think I'll take if you want. Dr. Kundan has written, breaking bad news, especially death, has to be declared by a senior doctor, preferably the main consultant, under whom, yes, this is what exactly I said. And Dr. Neha has written, in my department, I was the one breaking bad news and it was emotionally driven. Yes, absolutely. I completely agree with you. And once you have made connection and you make them say, and then you start doing the talking. I mean, that would come as a part of performance. But when you are going to break the bad news, please don't do it in hurry. A lot of time we think, okay, while going, I will talk to them. While I'm going home, when I end my duty, I will do that. So be mentally ready to spend some time and never do it in hurry. In between attending to phone calls or some visitors or going out and coming in and then asking somebody to come in to talk to you is not a good idea. Please manage all interruptions for those 15-20 minutes when you're talking to the family and the patient so that you can give them complete, attention. I have written again that please don't delegate. It is the treating doctor who should be doing the breaking of bad news. So coming to the place, now of course in all hospitals, at least the private hospitals, we have place called counseling room where we call the patient's family and we talk to them. But in a lot of government hospitals, we still see it is either done at the bedside or outside the ICU, outside labor room, outside OT. It's not a good idea. It's always better to do it in a separate place, make the party sit down, you sit down on top, because it's not like a 2-minute talk. It can go on for 15-20 minutes. So it's good to sit down at a separate place and make sure that there is nobody around so that only you and the patient party can talk one-on-one. When you feel comfortable talking about it, patients are comfortable listening to that. Plus, there is no interference from the bystanders. A lot of time, bystanders actually complicate the situation. They may say something or they may kind of, and our behavior also changes when we can see somebody overhearing our conversation. So it's always a good idea to sit with the patient party in a peaceful, calm place. You can have CCTV around. You can inform the patient party that our conversation is being recorded, so that they know that they have to behave properly, and you also know that it's being recorded. So there's a record of everything. So in case if you think that you cannot manage all alone, you can involve another doctor with you. You can even involve patients' relatives, especially whom you think will be able to handle the situation. Sometimes, senior family members, they act more, responsibly. They don't overreact to the news and they are able to calm down their younger relatives. So there's no harm having them around you. A social worker or a counselor or a senior nurse or a doctor, I think you can have them with you, because then it becomes easy to handle the emotional reaction that can come up. Having facial tissues, glass of water is a good idea. Sometimes it is important to calm them down, so you give them glass of water, or they start crying, to give them little time. If you offer them a glass of water, it kind of shows our human side to them, and also, you buy some time to allow them to calm down. Now, before you start telling anything, it is important to assess what do they know, and what do they want to know, and what is their idea about their condition. For example, if they have an idea, if they have been referred by another hospital or another doctor with already an indication that it looks like cancer, so we can't treat you and you need to go to a bigger hospital, and your hospital is a bigger hospital, so that means patient knows that I probably have cancer. So it's easy for you to take it further. But for example, a patient comes for a general checkup and suddenly you diagnose, breast cancer or ovarian cancer for a simple, general medical examination. So this is something they were not prepared. So definitely it's going to come as a shock. So you'll have to really stagger that news in a manner so that they, kind of mentally get ready. Now, a lot of patients would want to know everything. And you will come across patients who would say, I don't want to hear. If there's something serious, please talk to my family. Or they may say, you just do the treatment. I don't want to listen what it is. So you really need to actually ask, what do the patient wants to know, how much they want to know. And then are they really prepared to listen? As I said, if you are going to suddenly announce something like breast cancer or ovarian cancer, which has come out, as a routine medical checkup, so naturally they are not prepared for it. So you'll have to really, maybe call them once and twice to before you give them the news. And then you could even ask that, especially when there's only one patient and come alone. So it's important to have a family member around, and also It's important to know that, maybe the patient later on is going to say, oh, my husband is outside, let me call him in. Or my son is with me, so can I call him in? So it's always good to ask them right in the beginning that whom do you want to engage? If there's anybody waiting outside, do you want to calm them? So it's like making sure that you only share the information with whom the patient wants you to share. There is no harm even asking in a very simple way, I have something important to share with you. So do you want me to share like with everybody present here, or you want me to speak to you one-on-one? In case if the patient doesn't want, patient will express that, no, do it one-on-one. Or please talk to my family. Usually it is the family who would say that inform us first and then to the family. So you can see the conflict, the between the law and the actual practice. So you will have to be really smart at handling the situation. Now, if you look at the patient's information need, almost all 100% of the patient wants to know what is this disease. And they also want to know, give me as much information as possible because they want to understand it. But this can vary. This is a study from UK. In our country, it could be very different. A lot of time, son would say, don't let my, don't tell my parents. Or parents will say, or husband will say, don't tell my wife. So you really have to handle that. Now, again, in case during discussion, you get to identify illness denial or wishful thinking or unrealistic expectation, please do not let it go unaddressed. If you see the patient is just not ready to believe that it is something like this, although you will have to give them time, but you have to also give them the evidence that on what basis you are making that diagnosis. Or if you think patient has a wishful thinking, no, I know there's a doctor who would give this medicine and this treatment can be cured. So that means there's a wishful thinking that it will get cured, but if you know it's not, so you have to really help them understand more. And unrealistic expectations, especially if they're paid a lot. For example, the patient is in your care and they've spent lakhs and lakhs of rupees. So they already have this expectation that money is equal to life. So you really, in between, you need to check and also address so that later on there is no, extreme reaction. So all these things should be addressed appropriately at the right time. Don't postpone it. Don't postpone it. In case if there is misinformation, please correct the information so that they know this is what is the situation, and then tailor the bad news. If you think they are not ready for it, so you may have to stagger it slightly. So when the family says, please don't tell the patient, how will you handle it? How will you handle if the family says, please don't tell the patient? And we have seen a lot of time, family member says.
Yes, ma'am.
Ma'am,
Many times we come across family members coming up with this request, telling that their mother or father would get emotionally drained. Please don't let them know. Let's start the initial assessment and then we go ahead. So that time it really becomes difficult because certain tests or certain medications are very much indicative of the disease, and patient may feel betrayed if not informed.
So how will you, Dr. Neha, how will you talk to the family? Those who are saying that don't inform the patient. So how will you address it?
Madam, it has happened with me also multiple times. And in my practice, I have tried to explain it to the relatives that in some way the patient must be conveyed, at least not in a complete entire truth, that at least some part, so that they know ki, at least something is wrong there, something connected with the disease. Like it has happened in for the OT also, they have said don't explain it to, before in the PACs, that don't tell my father or mother that operation is for this thing. And consent, we have to take the consent also. So we used to explain that, okay, we don't say, if you don't say the cancer word, how will the further treatment go? first the resection will be there, then there will be chemotherapies or the radiotherapies. So somewhere you need to tell your father first. It has happened multiple times where we have given the chance. Okay, then they used to say, okay, then give us first the time, first we will go and talk. It has happened multiple times. I can remember multiple patients where they have said ki, first, in one of the cases, I clearly remember the son was almost ready to fight with me. No, nothing doing. So we had to counsel, myself and the surgeon together. Ki, please, first, if you want that we should not tell first, then please go, you yourself go, and please you can tell in your own way, and then we will go and we will tell in our own way in front of you only, in the milder way. And
Okay.
so that's
So
how we used to
what
do.
yeah, thank you. So what I would recommend here, I think one is that we have a tendency to underestimate patients' ability to take the news.
Yes,
We
you are right,
mostly
madam.
underestimate. So I
Yes.
think one is that we have to help the family understand that we underestimate the patient's capacity to take it. That is one. Second thing, why we should be sharing with the patient is because in case if it's a fatal disease and if, in case if there's very little time left. So I think we all think that, oh, I have a long life to live. So we leave many things undone, or we leave a lot of things pending. But if the person knows that I have 3 months or 6 months time with me, so there will be many things on the patient's mind that person would like to do before going. So it could be about will, it could be about apologizing, it could be about sorting out, it could be anything. So I think that right of patient should never be, patient should be deprived of. So help the family understand that why it is important for the patient to know. Third is, see, if it is elderly patient, if it's an elderly patient, they have seen life. So they have an idea when you take them for chemotherapy or when you take them for radiotherapy, they
know.
can make out, they may not know the exact word, this is what tumor, let's say it is something serious. So I think that's
one
how
thing, if I can just, madam, interrupt and tell, it has happened recently in a palliative center where we are, that one patient was admitted and almost, going to be the end stage or whatever. So the son was saying, don't tell my father. And the father was saying, don't tell my son. That finally going to happen, and that almost nothing can be done. So both knew each other, that they both wanted to protect each other, but both of them knew the things. So finally, the way the counseling was done, and then they were very happy. They held each other's hand, and then hugged each other, and both of them knew.
Yeah. So I can see answers coming from Dr. Amrit. So there are clear guidelines and legal instructions about patient being told about. I agree with you. And sometimes family wants to shield the patient from further hurt. Yes, that's the usual reason. So I used to work with adoption center for quite many years. I was there, psychologists who would handle, do the pre-adoption assessment and also adoption counseling. So whenever I would ask parents, do you want to share with the child tomorrow that you are adopted? So almost 100% of them will say, no, we don't want to tell the child that you are adopted. So, and I understand their intentions are very fair because they don't want the child to feel that we are not your biological parent. But then when I help them see, ultimately the truth is going to come out. And if it comes out from somebody, it's going to be a shock for the child. And later it will be, later it will be more damaging. It will be because by then the child has grown up and also would have a opinion of their own. Younger kids would know, but they don't know. So in a way, if you have shared with them at a young age, they know, but then they get acclimatized to it and they don't get affected by it. So once you explain to them, usually they understand that what I'm saying is making sense and they would accept. Similarly, I think telling the family that if the patient knows and if we are able to psychologically support the patient, their body also heals better if they know that they have to stay positive and be receptive to the treatment. So what I'm trying to say that this is one confusion, patient with HIV, for example. So they may say, don't tell my wife. There you have the discretionary power. Even if they don't agree, we have to inform the family, because then they can infect their partner. So that is where you will have to really, use your own discretion. So yes, we are legally and ethically obligated to get the request from the patient. If patient says, "Don't tell me, tell my parent," then it is a different thing. And otherwise, if you ask them what are their concerns and you address those concerns, they'll understand your point of view. And when especially you highlight the benefits of disclosure, they will agree with you, and we have to do. So coming to performance, I think very important, we need to be sensitive but straightforward. Don't beat around the bush. Don't try to reduce the severity. That will create vagueness and confusion. And balance between sensitivity and honesty. And avoid precise answers, rather than that give range. So they say, "Kitna time hai mere paas?" Instead of saying 3 mahine hai, or yeah, 6 mahine. Instead of that, if you say normally in this advanced stage, this is a usual time available. So give them a range so that they don't doubt your comment. And also, don't take away all hopes. Find some reasons to be optimistic, so you can take their attention to aspects where maybe survival is not possible, but then how can they make the end more meaningful or more memorable? That's also where I remember I had a client who lost her father, and she was still overcoming with this, and her mother became sick, and she was really into kind of a panic that I might lose my mother. So, and she said that, "I'm feeling very bad, and I'm fighting with my husband, and I'm fighting with everybody." So I just changed her perspective by helping her understand that, see, whatever time she is, if you can make that time memorable for her and for yourself, and create good memories, I think that will be the best service you can do to your mother. And it completely changed her perspective. She said, I now I make sure that I meet her frequently. I go to her and I, celebrate my small successes with her. So how you can, make them accept the reality and still not lose hope. That is something we have to learn. When you are announcing or when you are explaining, please use simple language, avoid technical jargon. If they don't understand, they don't understand. Then they're going to tell you at the end, "We were not told." So it's very important to explain in a manner that there is no confusion. And don't do a single monologue talking. Let them also talk. When you make them talk, you get to see how much they're understanding, what are their concerns, what they are agreeing, what they are not agreeing. So pause frequently and let them say or ask whatever they want to say. So in between, especially when you see them very upset or feeling very low, using silence and the kind of body language that you use can facilitate discussion and also help communicate compassion from your side. And make sure that you check for understanding, because a lot of time after having said everything, their last question will be, "Sir, patient bach to jayega." That means they have not actually understood. So this we have covered in detail earlier, so I'm not going to spend much time on it. Please remember, a lot of communication happens through your tone of voice and your body language. So make sure that your body language and your tone of voice is appropriate. When you start the meeting, greet them softly, make eye contact. Here, making eye contact is very important, because if you avoid eye contact, they may read it as though you are guilty or you are sorry for what is happening. So make sure that you make eye contact, you maintain open posture that shows that you are confident and you are sure of what you are doing. Tone of voice has to be, it doesn't have to be firm. It has to be more empathetic, but not like pleading, not sounding like guilt. If they want to say something, even it may not make much sense, allow them to express, because that will give you a chance to see how are they receiving it. And when they do the talking, make sure that you listen attentively. Don't start looking at phone or talking to somebody or writing something. Then they feel that we are not paying them, sufficient or appropriate attention. Nodding, we all know, helps to communicate that yes, I'm understanding, I'm agreeing. A lot of time that emotional reaction that comes from them could be just an emotional outburst of not being able to accept what it is. So we don't have to react to it. We don't have to give tit for tat. Sometimes even being quiet is all right. Therefore, if you are doing it in a separate counseling room, in case if the patient becomes little aggressive and you stay calm, patient will calm down. If it happens outside and there are people observing you, you are likely to react with equal amount of aggression. So therefore, it is always a good idea to sit and do this activity. And then comfort the patient or family with appropriate verbal and non-verbal. So these are different ways you can use to start the conversation. When you say, I'm sorry if the report is not very encouraging, or if you say, I really feel bad to tell you that reports are very, are very discouraging. So basically, or you could use any other way if you don't want to sound like this. I mean, if you say, tell me about the report, unfortunately, report is not okay. So that shows your human side. That's the whole idea. Rather than straight away going and saying, कि आपकी report आ गई है और report में पता लग रहा है कि आपका stage 4 cancer है. So that comes as a very blunt statement from us. Now, how does that bad news hit the patients? Actually, it results in cognitive, behavioral, and emotional deficit. So therefore, you will see patient will appear shocked, speechless, don't know how to react. So you can't change the news, but you can definitely, make them feel better by giving a realistic hope and also avoiding any cold behavior to their behavior. So studies suggest almost 50% of the patients respond with shock. Almost 46% expressed that they were frightened. 25% patient reported sadness, 40% accepted, and 50% said they were not affected. So everybody reacts differently, but usually the patients, you will see them crying or becoming silent, or they may ask you, are you sure? Or they may say, maybe if it's a wrong report, can I take a second opinion? Would you like, can we get the same test done once again? So that shows that they are not able to accept the reality. The inner response is called dabda. I'm sure you all must have heard it. So dabda is that they are in denial when they're not able to accept. They may be angry, unhappy, aggressive, revengeful, blaming, because they may ask, why me? Or they may say, you haven't done enough. Or they may say, you have wasted my time. Why did you not right away send me to cancer hospital? You wasted by 3 weeks' time and the disease has spread in my body. Because, for them, it is, again, because of denial, they are angry. Or once they realize that it is the reality, they will start bargaining with you, saying, whatever treatment is possible, please do. If you need some medicine that is not there in the hospital, I'm ready to get it. I have my relatives in America, I have my relatives in other countries. If you want, I can get the medicine imported, but please give the best medicine. So they are more into bargaining mode where they think that I wish something could be done. Again, once they are settling with the reality, they suddenly become quiet and they appear depressed. And finally, they may accept the reality. How do you handle these situations? If you see denial, provide them information so that they get to know that you are not making any imaginary diagnosis, but you have a reason to believe that this is cancer or this is HIV. When they're angry, I think we have to stay calm and listen to them and be supportive rather than retaliating with the same amount of anger and aggression, because that's going to aggravate. When you see them bargaining, help them see the reality. Let them know that money is not equal to life, and whatever best can be done, you are doing. And you can assert also in this moment where you help them see, the treatment-wise, the patient is getting the best possible treatment. If you see them becoming quiet and confused and appearing depressed, I think that is where you need to give them direction. Now, what next needs to be done? It could be another test. It could be going another hospital. It could be going and meeting another doctor. So you'll have to give them direction so that they know what next they have to do. When you see them accepting and when you see them, being open to the idea that, okay, this is what it is and I need to, now handle it or face it, that is where your encouragement will help. When you say them, I really appreciate your, strength or your willpower to work on. Empathy, I think we have talked enough about it. At this place, I think this will really, really help you in communicating that you understand what they're doing. And I'm sure each one of us have seen somewhere, tough times in our life. So if you can recollect those moments, I think you will understand patients and the family's plight. It's a great tool to create solidarity. These are few examples you can use in your dialogue with the patient party. When you say, I know you were not expecting this, and it's difficult for anybody. Even I was hoping for better as well. So that's how you kind of show that I am with you in the hours of crisis. Nurses and residents play a very big role, although they are not supposed to, nurses especially and the technical staff, they are not supposed to, update the family or break the bad news. But at the same time, I think their behavior and conduct with the patient party has to be more humane, especially if the condition is critical and the patient is unlikely to survive. We need to be more considerate and compassionate with the family member, especially if the patient is in ICU, relatives want to visit the patient, and we are rigid on the point that no, we don't allow, beyond visiting hours, you have to come, in the evening at 5 o'clock, we can't allow you to meet. And then unfortunately, if the patient dies before the next meeting hours, I think they're going to be very unhappy with us that we did not allow them to see the patient alive. So in those cases, I think nurses and doctors and support staff need to be more understanding and more considerate. And I'm not saying allow everybody and anybody to get in, but then if you allow the immediate family members for a minute or so and then give them clear instructions that you can't go and touch the patient or you can't disturb the patient, just go and look at the patient. Actually, it will help you, because when you allow them to see the patient, you will see them when they come out, their facial expression and body language actually shows that they have a realization that the patient's condition is very bad and the chances of survival are very, very, very low. So it's a good idea to allow them to see the patient. That will help them get medicated. Talking about the clinician's perspective, I think very seasoned clinicians also experience stress when they have to break the bad news. Usually the stress is before they do and while they are doing the breaking of bad news. For patients, it is when they get to know the news. But clinicians experience more stress when they are going to do it, because there are a lot of questions and doubts in their mind, and they don't know what is going to unfold. So they may have, they may be uncomfortable about the patient's expectation. They may fear that they are going to destroy the patient's hope. So how is the patient going to react? They could also feel inadequate in the face of uncontrollable disease. We always think I can do anything, I can manage everything. But we know there are certain conditions we cannot do much about them. And then we are sometimes not prepared to manage the anticipated emotional reaction. I've deliberately written anticipated emotional reaction. We should know these emotional reactions are bound to happen. That is how the human mind processes any, sad news. So we need to just know how do we handle that without being too reactive. Can we stay calm and allow them to vent and then calm them down? So sometimes, we paint a very optimistic picture, and if something goes wrong, then it becomes very challenging to explain to the patient party why did it happen. So for example, I remember an eye chain in Delhi had this tagline, "Ghar se aiye, surgery karwaiye, office jaiye." So come from home, get this surgery done and go to office. You need not go home. This was the tagline of one of the eye chain. But I'm sure when some nucleus drop happened and some vitreous hemorrhage happened, I'm sure they must have realized that these are too, raising their expectation. So remedies for this is, I would say, please give realistic expectations, accept your professional limitations, learn to control emotions, because our emotion and patient's emotions, they are both needs to be managed. So keep the family updated so that they are, kind of prepared for it. And then document all communication. The thumb rule is document what you communicate and communicate what you document. Common mistake in breaking bad news is that we either try to avoid the breaking of bad news as long as possible. We don't tell the patient. I think I told you in one case where the patient had to go for undergo foot amputation. The doctor had already decided it was a young patient, but patient was not informed. Patient was even sent for PAC. And suddenly when the anesthetist asked this patient, where are they going to amputate your foot, from which place? So that lady said, what is it? Nobody told me about amputation. What are you talking? So imagine you have already decided that this is what you need to do, but you are not informed patient that this is, of course, you will not amputate without informing, but why delay and why not tell them, on time so that they also get mentally prepared for such a big, change of life. So sometimes we see people just not doing and hoping someone else will do it. So they will not tell if there is something wrong. They will think either patient will not get to know, or maybe some other doctor, when they will examine, they will get to know and they will inform. We have also seen people lying, or they are not again telling the truth. They're playing with words and they don't tell the truth. Sometimes they will not pick up the patient's cues. They can see the patient is angry or aggressive or not believing or not accepting, but they will not, deliberately pick up those patient's cues. And then a lot of us do the activity in a very mechanical manner, where patients feel that we are not understanding the emotional impact of that news on them. Once you break the news, I think they fear that we are going to abandon them. It's very important to reassure them that we are not going to, abandon them, but we are actually going to establish a treatment plan, treat their current symptoms, discuss the next treatment plan, and establish a time for follow-up. So it's important in case if they need to be referred to a different doctor or a different department or a different hospital. So give them the contact details, arrange for the appropriate referral, and if possible, involve people like family, friends, social workers who can provide emotional and practical support. Because I know a lot of clinicians are not very comfortable handling this aspect of patient management. Why not have people who can manage these things appropriately? So to quickly summarize, I think most patient wants to know, and if done rightly, it improves patient-doctor communication and relationship. It helps patient and family cope up with the situation. It fosters a collaborative relation and can prevent aggressive reaction. 6 steps to breaking bad news is prepare, find out what the patient knows, find out what the patient wants to know, share the information, respond to emotions, and plan and follow up. I think disease and death, we are not familiar with till we experience it personally. But once we have seen it closely, we understand how it impacts the patient and their family members. I don't wish anything of that sort for anybody, but then it really changes us. It makes us more humble and more understanding. So this is about breaking bad news. Any questions?
Ma'am, I just want to share that most of the times I have seen, and in case of my own father, I have seen that very senior consultants also don't convey the bad news in an empathetic manner. And in my father's case, there was no clarity about what is happening with my father. So, no, we lost him, but the closure to him, it came very later. Because being a doctor, I was knowing what is happening with him, but they were not updating us.
I agree and I understand completely. You are very right. Now you see, if this is what you have experienced, imagine the layman's life.
Yes, ma'am, I can understand it completely.
And most of it is because we don't know how to handle this situation. It's not that they have done something wrong, but they are not able to communicate even this much, that only this much I can do. Only this much can be done in this case. Because we are not ready to accept that we have our own limitations.
Ma'am, at 2 o'clock in the afternoon, he said, my father is fine and I can go and have lunch. When my father was going to die within 2 hours. And at 4 o'clock, I received his call that my father is no more. And at 2 o'clock, he discussed with me everything is okay, Dr. Manisha. Urine output, we are having urine output, and he is showing some signs of improvement. So I really couldn't understand once he called me and said that, no, 4 o'clock, your father is no more. And then he didn't even come to meet me. He sent a very junior person to ask around the ICU that the lady who is with bed number so and so, when he is knowing I am a doctor and I was working at FMRI, Gurgaon, at that point of time. So, I mean, if senior clinicians from the fraternity respond like this, then, I mean.
So you can well imagine the plight of general patients. I'm sure you will understand.
Ma'am, I have seen also. So, I mean, I understand what you have
You all will
conveyed.
be wonderful doctors when you will be handling those situations. You will understand the patient's plight. I am sure. So I think it's already 10 minutes to 10 and not 10 minutes, just 5 minutes to 10. And we have two presentations, one by Dr. Amrit and the other one by Dr. Priya. So Dr. Amrit, have you shared with me the presentation? Have you emailed? Kindly unmute. So Dr. Priya, I think you can start the presentation.
Ma'am, please let me come in again. By mistake, I logged out from my iPad.
Okay.
So sorry.
No problem. You can log in. Yeah. So Dr. Priya, meanwhile, you can, but Dr. Amrit, have you shared your presentation in email?
Ma'am, I have mailed it to you. Please let me in the meeting, please.
Yeah, but you're already there. You're talking to me already. You have to switch on your audio video.
Hello.
Dr. Amrit, you are there. Just have your video on. Please have your video on. So Dr. Priya, you can start.
Ma'am, I have shared it with you in your mail.
So I'm going to, open it up. Meanwhile, Dr. Priya can do her presentation.
Is my screen visible?
Yes, we can see it. Yeah.
It's a short, a very short study I would like to present. It's a case scenario. There's an outstation camp that has been organized with a huge propaganda online and offline. And the local corporator as well is very keen on the success of the medical camp. And now on the day of the camp, a day before, a hospital representative, a senior male doctor and a lady doctor are traveling to the location. This location is in the outskirts from your hospital and not in a network zone and almost 14 hours away from the hospital. Now on the day of the camp, just 2 hours prior the camp, the lady doctor walks up to the hospital representative and tells that she cannot be part of the camp as the other doctor misbehaved with her. Under this situation, what should the representative do? I would want you to think over the situation and then put yourself in the shoes of the hospital representative and let me know what would be your next move. How would you handle the situation? What will you do? What would be your stand? And how are you going to handle the situation? Would anyone like to answer the questions? Anybody thinking of it? Okay. Fine. I'll go to the presentation now. My presentation today is about case study with a brainstorming session as a pedagogy. So with the presentation, you would have got a gist of it. So it is case study is nothing but a kind of an event or a particular situation which is brought into as a case study so that there is a group discussion involved. People start thinking, there's a lot of involvement that would happen. A quick look how this could be useful. We could have it in a training session. We could have it as a part of any kind of a disaster management. Could be a case discussion, could be completely a clinical or a non-clinical, like how we discussed just now. Could be on case studies, which happens in the emergency zone, how we handle or tackle the emergency situations. Now, there are golden rules that we should always stick upon when we start case study as a session or as a pedagogy. The first one is how you would start, what idea you would want to put across to your participant or to your audience. And it can be successful with a good idea that is in place. And it should not have any specific note or specific restrictions as to what you should think and what you should not be thinking. As well, you could always adapt in new techniques or some innovative process. You could even bring in people to enact the scenario so that, they start thinking more about it. So you could put it the way you would want to present it. Now, advantages are quite a number. Obviously, after the case is presented, it brings in a lot of attention. People would start thinking analytically, thinking hats are on, people are into the discussion. There is a lot of exposure to the situation or a particular case that you would want to present, or maybe the topic is on leadership, maybe the topic is on managing situations. It could be any of these, but it will pull in the crowd. And they would really think about it, even if they are less interested or it may not be their topic of choice or interest as such, but they'll still would think about, because it's a situation that is in front of us and we would want to know what is the solution for it. Then obviously would give in a very relaxed environment, a relaxed approach. It will also encourage a creative discussion and a thought. Now, disadvantages also we have. Now, one of the disadvantages is maybe few of them may not be interesting, may not have full participation. There may be participants who may not be very keen on understanding the case study. Maybe it's not part of their subject, or they may not have come across a situation like that. And there are chances that few of the participants would start talking a lot, or, the whole of the discussion goes on a different pace. As well, the time constraint is very important for you to notice, because any kind of discussion can go longer than we expect. So you need to have a control on that. And the worst that could happen is arguments. A group of participants will always have different objectives, different ideas, and difference of opinions when it comes to a very critical subject. So you need to deal with the situation, ensure you don't end up having an argumentative session and then leading to something else. Then don'ts. I have put in don'ts first before the do's. Now, don'ts are, do not let people to hold on a conversation and control the whole scenario. Obviously, don't ignore the clock. You have to keep a watch on the time. Then always do not expect that the crowd would come up with something that you would want them to do. There are always different perspectives, a different scenario, and a different way each person thinks about. You may even come up with something better than what you would have thought of as an answer. And obviously, if there's been a huge argument between the crowd, ensure that it is sorted and cleared before the next session or the next brainstorming. Do's, not very easy again. You need to have what exactly they need to do, what is the discussion, where we need to arrive at. And there obviously has to be a person who's going to handle the whole scenario, something like a moderator who controls the situation. And then start off telling with a high note or a high level that you are holding such a position and you need to take care of it. So the small, minute things are not focused upon more. Time box, yes, take care of the timing. Do not give away the situation or give them leading answers. Let them do their task and let them come back to you. Thank you. So this would be one of the very good pedagogies to start with. Thank you.
Thank you, Priya. So anybody would like to give feedback to Priya about her presentation? Priya, can you stop sharing your screen? Yeah, thank you. So anybody would like to briefly say a few words of appreciation for our efforts? Dr. Deepika, okay, go ahead, please.
Thank you, Dr. Priya. It was a really nice presentation. It was very, very clear and to the point. And I really liked the way that you presented with a lot of good pauses in between. And I also like the pedagogy that you selected of discussing a case and brainstorming. Thanks for that.
Wonderful. Thank you, Deepika. So can I request Dr. Amrit to, should I share the presentation first, or you want to first do the talking and then?
Ma'am, we can do it simultaneously because I think we have done the role play today also, and we have done it a lot many times. So everybody is aware of what exactly it entails. So I think we can go on with the pointers now.
Yeah. Go ahead. Yeah.
So today I'll be discussing this role play as a pedagogy. Pedagogy or pedagogy, both are correct. There has been a confusion. So role play, it is a dramatic strategy. It involves people taking on specific roles and acting on them in a situation-based scenario for the purpose of learning course content or understanding complex or ambiguous concepts. Where it can be used, this pedagogical tool can be used in various fields like medicine, law, business, psychology, marketing, counseling, teaching, debating, etc. What are the steps of role playing? First is select a topic or a problem which is to be enacted. Next is selection of role players. That is to facilitate the enaction of the roles demanded by the situation that we are presenting. Then is setting the stage for role playing. This is very important. It entails making necessary setup for activity where participants assume the identity of other persons and then respond as they perceive their behavior in particular circumstances. And sometimes this also depends on the topic we are taking up. Say, for example, if we are doing this role play related to a BLS training, then we might need a dummy also in the settings where we can demonstrate the steps of this training. So next is, ma'am, I'll be needing to see that more.
Sorry, I'm so sorry.
Yeah. Then is preparing the observers. It is done by assigning the role of observers to those who are not acting in the role play. Next is enacting the story. Here there should be a script for it, which makes it easier to do it. Then is the discussion and evaluation. It concerns with free and frank discussion about the quality of roles. Now we come to the advantages. It is enjoyed by the people who do it as an activity. Role play is usually modeled on realistic criteria so participants can get close to the real thing. People can learn skills used in real world situations such as coordination, cooperation, teamwork, etc. It provides real life scenario to help people learn. So it is close to reality. And it also motivates and engages participation. It helps enhance the interest in a problem. It helps build self-esteem and confidence. Unlike simulations and games, it is usually short and spontaneous. The disadvantages of this pedagogy might be, it may not go according to the plan as it is an impromptu exercise and may have unpredictability. and can be chaotic. Sometimes the script is understood by different people in different ways, so there might not be a lot of coherence in the outcome. Participants may not be convinced about it or may be skeptical, and their participation may not match the expectations. It may be compatible with one group and may not work for another. Next is the task might be misinterpreted and participants may get carried away. It may also cause embarrassment, discomfort, and awkwardness to some participants because most of us are not trained actors and it might be the first time we are performing. Rules of role playing are: make sure the participants are willing to do it. Nobody should be forced against the will to perform. It should be tied to learning an objective relevant to the content of the course. Then allow the participants some practice and contemplating time, content planning time, because to avoid the outcome going haywire or people going haywire with their expressions also. Then a larger content can be broken into smaller sections for better understanding. When assigning goals, explain the purpose and answer questions so participants are able to prepare properly. Explain guidelines about general presentation behavior like eye contact, gestures, voice projection, appropriateness of language, etc. Also ensure participants are comfortable, as any awkwardness will impact the quality of the role play. When debriefing, refer to the characters in the role play and not to the individual actors. In feedback, point out all the positives first and then what could have been better. Don't interfere with the role play when it is in progress, because that may affect the outcome. People may forget their dialogue, they may forget what they were about to do or supposed to do. Participants should avoid pushing, shoving, grabbing, or other physical contact. Don't speak for other participants. Let them find their words if they are missing some dialogue or they are trying to find the thread in the performance. Don't include people who are reluctant and not ready to spare time. Don't rush to rescue people and let them find their solutions on their own. Don't target too many learning points in a single role play to avoid confusion. Don't make jokes at expense of participants, as most of us are awkward actors, especially as we are being watched. Thank you.
डॉक्टर नेहा, आप अंधेरे में क्यों बैठे हैं?
अभी लाइट चला गया है तो बैकअप जनरेटर लाइट विल कम. अभी आ गया.
Good. So who would like to give feedback to Dr. Abdul? Chalo, go ahead, Dr. Neha. Go ahead.
Excellent presentation, madam. First of all, the way the pictorial things were made, it itself is so impressive.
Thank you so much.
From the beginning only, it was very impressive. Even the first slide. So those beautiful diagrams, I mean the pictures, and of course the presentation content-wise also very clear, concise. Everything was very clear. So excellent presentation. Very soothing to eyes. Also, the color chosen were very soothing to eyes.
Thank you so much.
Dr. Amrit was very apprehensive. Will I be able to present well? So I think
I was, ma'am. My maiden performance. For the first time, I did something like this in my life.
So good, so good. You did very well.
Thank you, ma'am, for motivating. Actually, you motivated me, pushed me. You have to do it. Thank you.
We have done it. We have done it. We just did that push. Chalo. Then any other question after this? Anything to ask Priya or to Dr. Amrit or to me?
I want to ask something from you, madam.
Sure.
All these, ma'am, whatever these YouTube, all those things, what you put up. So how long we can access this if you want to see this?
It is there. I'm not going to remove them.
Okay. So, and can we download and save these?
You can, but I think it's going to be a huge file.
Okay. So I
can
just
check.
wanted to know.
You can, no problem. So two things.
Ma'am,
Yeah.
one
yeah.
more question. Ma'am, my question again remains because I had put it in the chat box. I was not saying, but I was asking, are there any guidelines for breaking bad news? I mean, whether to disclose it to the patient or not. Are there
There
any
are.
clear guidelines? Okay.
Yes, there are. There are. I mean,
This
one
is
of the
what I want.
patient's right, because whatever the patient's information is, we cannot share without the patient's consent. In our country, it's very different. Reality is very different from the theory that we talk. But if the patient wants, they can sue us. But can we take a midline where we at least ask the patient verbally and then make sure that we are not sharing the information with the wrong person? I mean, carelessly sharing with anybody. Earlier, what used to happen? Anybody will come in, they will open patient case sheet, have a look, and go away. Or they may go and ask the nurse, how is the patient, what is happening. Even other patients from other beds, they will ask, and the doctor or the nurse would share. Now, I think we are more particular about it. We don't share the information easily. And we have to be further more particular because we would be breaching the contract with the patient. Dr. Kundan, you wish to say something? Please go ahead.
Yeah. So I think excellent presentation by Dr. Amrit and Dr. Priya. I just want to, regarding the breaking bad news, I just want to share something like, I don't know, it's a little bit philosophical that, birth and death is not in our hands as a treating doctors. And we are not the last hope for patients. So that I think should be in it, because many times the patient who should be surviving for 6 months survives for 6 years. So there are a lot of options available to patients apart from us. Faith healers are there, alternative medicine is there, so many things. So I think only we should speak what our science speak or what our expertise speak and give a guided prognosis, especially when it comes to somebody's prognosis, death or survival. So I think that should be kept in mind, because there have been cases where we have said that, he won't survive, and also, and then the patient defies the logic. So I think that has to be, that humble thing should be there in us whenever we discuss, even of course when it's death, then of course there is no option, but then grave prognosis or chronic disease, I think that many times patients, when they have the right to choose about their life, they can make, even the court also agrees that patient have the right to take decisions on for their life. We have to guide them, but we have to speak only what our science says and not beyond than that. That is what I feel during the.
Thank you for adding that point, and that's true. A lot of time patients say that there's a Ayurvedic medicine available. If we don't know, we can simply say, see, I have no idea, but it will be good if you speak to the experts of the subject. Maybe they can tell you better. But normally we get annoyed, and then we kind of say, I mean, they will make a fool of you, and then why do you want to go and check with them? I think this particular thing is rampant among us. So it will take a lot of time to actually become comfortable with the idea that others, medicine system can be equally effective or could also be explored. But I'm glad that you are bringing that up, and more doctors should become open to the idea. That's very, yeah, go ahead.
I would like to add something to what Dr. Kundan has said. One real life experience, like what he said, the survival goes beyond what we say. So there was one army person, and came for CA esophagus patient. And actually, when I joined this Dharamshila hospital, he had come for some biopsy and all. And then he was, and then I forgot biopsy was done, and definitely he went away from the OT. Then again, after some 1.5 years or so, again he came back for some procedure in the OT. So he recognized me. I had forgotten, I mean, his face or whatever. So he said, "Doctor Sahab, aapne mujhe pehchana." So I said, "No, I'm sorry." So he reminded me, actually, "Doctor Sahab, मैं ऐसे ऐसे आया था 1.5 साल पहले, और मुझे बताया गया था कि मेरी लाइफ एक्सपेक्टेंसी 6 months से ज्यादा नहीं है. So, but I am here." So I said, "It's very nice." So he said, "मैं आपको बताता हूँ मैंने क्या किया." He said कि मैं बहुत स्मोक करता था, अल्कोहल लेता था. So जब मुझे ये बताया गया कि 6 months से ज्यादा एक्सपेक्टेंसी नहीं है, so I said, okay, मेरे पास जितना समय है, let me live that life. I took all the treatment. I stopped smoking. I stopped drinking. I started going for a walk. I did what I wanted to do for my family. I made a will. I arranged everything in order that my family does not suffer. I took care of all those things. I did what I wanted to do for so many years, but I could not do. But when it came as a blow like that, oh, I just had 6 months expectancy only, then I did all those things and started living with positivity in my mind. So I can never forget this case. And I quoted this case to many of the patients who used to come in counseling them, and they used to become very positive with that.
I completely agree. So I can read a comment by Santoshi in the chat box. She says American Heart Association as a part of their ACLS program, they do have scenarios of do's and don'ts to be followed while declaring bad news to the patient. That's so good. I think that is what is the training required for everyone, including doctors, nurses, paramedical staff. They should know what their role is and how they are supposed to be doing.
Yeah,
so I can see two hands. One is Dr. Amrit and Dr. Manisha. Yes, Dr. Amrit.
Thank you, Dr. Kundan, for saying this, because that is very true. And me being a homeopath, I am actually a witness to many such cases where the patients were given a certain time to live and a certain outcome which was fixed for them, a bad one, and we could alter the outcome for the patient, and patient lived for much longer and remained rather healthier for a long time. So this has to be considered. We cannot close all the doors in one.
Yeah, why not? Why not?
Thinking that our system can do this.
Absolutely.
Yeah.
Thank you. Yes, Dr. Manisha. And then I think Mamta also wished to say something.
Ma'am, the living example was Louise Hay. She was detected with cancer, breast cancer. She became an inspirational speaker. She healed herself and healed many people who suffered from cancer. And no, she talks about positivity. She talked about affirmations, and she has a set of books where it is heal yourself. And
So whom are you talking about? Sorry, I didn't get the name.
Louise Hay.
Achha.
She's an a well-known inspirational speaker from America. She was detected with breast cancer. She healed herself, and then though she went on a journey to inspire women and people who were suffering from cancer. During her journey, she wrote a series of books which are available, which are world famous, and she died 3-4 years back only. And she was an inspirational speaker. She has explained how we can convert our subconscious mind, and how by positive affirmations we can heal ourselves. And in fact, she helped a lot of people to heal.
Thank you. Thank you. So Mamta, you wish to say something?
Yeah. Hi, ma'am. So my question is it's for you, ma'am. So it's been almost 8-9 sessions I have been attended. The core concept, what I understand in communication is talking right thing at right time is what communication. So you are being from psychology, PhD in psychology. So that is the reason you are very much equipped with connecting dots of communication. So I just wanted to know, ma'am, and I think talking right things at right time will not come by chance, or like we need to train ourselves, train our mind. So in psychology, are there any kind of models which help us getting trained ourselves in practicing these things, ma'am? I know this is out of context, but
see, reading some good material definitely helps us. For example, if you want to work on your demeanor or you want to work on your language, so there are so many YouTube videos, TED Talks around it. Rather than looking for book, I would say listen to these, because these are very crisp messages, especially delivered by very seasoned speakers and who actually share their lifetime learning in that 5-7 minutes. For example, if you will watch that book, TED Talk by Dr. Devi Shetty on the power of touch, I think you would understand what exactly is the meaning of touching the patient and what that does to the patient. So same way, there are so many speakers and so many, people who have given, and I actually love listening to TED Talks because they're short, crisp, 5, 10, 15 minutes, and you get a huge message out of it. I mean, you don't have to look for a message in the book, because books are, of course, interesting if you have time, if you have that much of, spare time. So I would suggest listen to TED Talks and YouTube videos. You will find a lot of them. Even on assertion, the right way of handling conflict, on assertion, these are the things you can definitely find on YouTube videos and TED Talks. So thank you so much. I think it has been a wonderful discussion with all of you. We are left with just one more session, and I'll be sharing the feedback for today's session. Some of you are rating the pedagogies presented by the participants. I request in your feedback, don't do that. We will talk about what we are doing in the main session. And another point I wish to make is that I would request you for the next session to be also on next Monday. Incidentally, I have a lot of travel. Every Wednesday, I'm traveling for almost 4 or 5 days. So I'm going on this Wednesday and coming back on Sunday. So going to Pune, first to Ahmedabad, then to Pune, and then to Trivandrum, and then come back on 18th. So it's going to be a lot of this thing for me. So humble request to all of you. If you can have the next session on coming Monday, that is 19th. That's okay with everyone.
Yeah, it's okay.
Sure, ma'am. For
It's
us,
okay.
for me,
It's
as
okay with us.
it will work.
Sure, ma'am, it will work. Yeah.
Thank you. Thank you so much, everyone. So I'll close the session here. You all have been wonderful audience, excellent, participation. You see 10:30 and you are still awake with me. Thank you. Thank you once again.
Thank you, ma'am.
Thank
Thank
you,
you so
madam.
much.
Thank you.
Good night.
Thank you, ma'am.
Good night,
Good
everyone.
night.